we have Gaoyuan Huang for a presentation on C3 glomerulopathy.
Hello, everybody. I think I don't need to introduce myself. My project is about C3 glomerulopathy after kidney transplantation, and my mentor is Dr. Jefferson. My last grant round provided the most background information for my study, but for a quick reminder, C3G is a single criterion histological diagnosis defined by C3 deposition at least 2 orders of magnitude greater than any other immune reactant on immunofluorescence. C3G is an ultra-rare disease, including C3GN and DDD. There are only 11 studies about C3G after kidney transplant, including only 164 cases. So even though our study cohort is small, we will be able to still add value to this field. The total C3G recurrence rate is 57.3%, which is high. Graft loss rate varies from 11% to 77%, but in half of the studies, it's more than 50%. Our study is to describe the clinical pathological features influencing recurrence and outcomes of adults with C3G after kidney transplantation, and assess the heterogeneity of C3G among individuals at the University of Washington. All C3G patients who underwent kidney transplant at the University of Washington from 2000 to 2024 were identified. Thank you. By review of the renal pathology database, 12 subjects with complete data were analyzed, including 10 C3GN and 2 DDD. So this study is actually about our 25 years experience in this field, even though it's just the 12 subjects. But Dr. Jefferson asked me to be humble, so I didn't include that in my title. I'm going to present my results in 5 different parts. Part 1, clinical characteristics prior to kidney transplants. This table listed all our 12 patients. I'm not going to read all the data here, but I want to point out that in the green box, there are 3 cases who were diagnosed before age 18. And when you look at the time from C3G diagnosis to the first kidney transplant, most of the patients progress to ESRD within 5 years after C3G diagnosis. But there are 2 cases in orange. They had extremely slow progress. They progressed to CKD4 over 30 years after C3G diagnosis. Why they are so special, we don't know, but it showed the clinical heterogeneity of C3G. Are there any differences between recurrent group and the non-recurrent group in terms of the clinical cost before kidney transplant? There are 7 patients in the recurrent group and 5 patients in the non-recurrent group. In our cohort, patients in the recurrent group had a shorter time from C3G diagnosis to dialysis and a shorter time from C3G diagnosis to first kidney transplant, indicating a more aggressive native kidney disease course, which is also consistent with the prior studies. Also in the recurrent group, all the patients had a low C3 at kidney transplant. So the question is, are low C3 at kidney transplant and a more aggressive native kidney disease course associated with higher recurrence risk? We don't have a definite answer to that given the small sample size, but I think that makes some sense. Part 2, post-kidney transplant C3G outcomes. In our cohort, post-kidney transplant recurrence rate is 58.3%, and the time from kidney transplant to recurrence was 5 months with a range of 9 days to 25 years, which is consistent with the prior studies as well. But our graft loss rate due to C3G recurrence is 28.6%, which is lower than most other studies. So it seems we're doing better. But I have to point out that in early published studies, no one used complement inhibitor at that time. Most of our patients, 7 out of 12, used the eculizumab prophylactically after kidney transplant. We're not sure whether that has improved the prognosis. But anyway, despite high recurrence rate, only 2 out of 12 C3G cases had graft loss after kidney transplant, endorsing kidney transplant eligibility in C3G patients. I think this answered case question during last grand round. Are there any differences between C3GN and DDD? Consistent with other case series, DDD in our cohort progressed to ESRD more rapidly than C3GN, and it was associated with a higher recurrence rate and higher graft loss rate. But different from prior studies, our DDD cases recurred much later than C3GN after kidney transplant. Also, in the literature, half of the C3G patients had graft loss within 5 years of recurrence in Western populations, but our C3GN patients had a much lower graft loss rate and a longer time from recurrence to graft loss. So it seems our C3G patients had better outcomes after kidney transplant, even though there is no statistical significance given, again, the small sample size. But this is still a very encouraging finding. Part 3, evolving histopathological changes in C3G. In case number 5, we observed light microscopy pattern changed after kidney transplant from mesangial proliferation to MPGN. And after eculizumab treatment, C3 intensity decreased from 4 plus to 2 plus, which was reported in prior studies as well, even though clinically the patient got worse. It seems eculizumab didn't prevent C3G recurrence or C3G progress, but whether eculizumab has slowed down the progress is controversial. We had very interesting findings in this case number 7. This patient had classic IgA nephropathy for 13 years, then changed to C3GN without any IgA deposit. After kidney transplant, the patient had a recurrent C3GN, then changed to immune complex MPGN. We talked about the shifts between immune complex MPGN and C3G during my last grand round. They have similar level of genetic and or acquired alternative pathway abnormalities, and they may be part of a broader disease spectrum. This shift from IgA nephropathy to C3GN is a new finding. I haven't seen any report about this before, so I'm very excited about this new finding. But we know that alternative pathway is the major complement cascade activated in IgA. And glomerular C3 deposition has been shown to correlate with disease progression. So that may partially explain the shift. Part 4, monoclonal gammopathy of undetermined significance and C3G. We have been always concerned that MGUS may contribute to C3G recurrence if we don't treat them, as seen in number 2 and number 4. Sometimes monoclonal components in MGUS can act as autoantibodies or inhibitors to alternative pathway and cause overactivation of alternative pathway, resulting in C3G recurrence without any monoclonal immunoglobulin or light chain deposition in the kidneys. But C3G may not recur even if we don't treat the MGUS, like this case number 8. So the conclusion is MGUS is not necessarily associated with C3G. Part 5, complement test and personalized management. Total 11 patients were tested. 5 patients had complement-associated autoantibodies, which act as the drivers of alternative pathway overactivation, including C3NAP, C5NAP, and factor H inhibitor. 2 patients had complement-associated gene variants, number 12, was found to have a heterozygous variant in factor H gene and low factor H level. This factor H variant could be a driver of C3G. How can we use complement tests to guide personalized management? This is the most exciting part to me because there are a lot of new medications in the pipeline, and hopefully we can provide more targeted and efficient treatment options to our patients. And the primary function of factor H is to bind to C3b and act as a cofactor for factor I to inactivate C3b. Is a break of all three complement pathways. Factor H deficiency caused by factor H gene variant or factor H autoantibodies results in overactivation of complement pathways. This new drug, KP104, is a combination of factor H component and C5 antibody. So it's designed to to replenish the factor H and inhibit C5. So blocking the upstream and downstream of alternative pathway at the same time. So hopefully it can increase the factor H, treat the factor H deficiency, and halt this process. But it's still in phase 2 trial. C3NAF is an autoantibody which stabilizes the C3 chromatase in the alternative pathway. There's no drug directly targeting C3NAF, but we can try to decrease the production of alternative pathway C3 chromatase through factor B inhibition or factor D inhibition, or we can just try to target the downstream inhibited C3 binding to the C3 chromatase. So factor B inhibitor iptacopan and C3 inhibitor pegcetacoplan can work like this. For patients with C5 NAF as the driver, they can use the same medication list to block the upstream of alternative pathway. For C3G patients who haven't had recurrence yet, it may be helpful to have protocol renal biopsies to monitor early histological recurrence and start treatment early. Because we noticed that the patient can have very early histological recurrence, but will not have the clinical recurrence until maybe 1 year after histological recurrence. So I think that would be helpful. Also, monitoring alternative pathway activity may help detect early recurrence as well. For patients with high recurrence risk, such as this number 10, who has the driver and overactive alternative pathway, prophylactic use of complement inhibitor is reasonable. We have been using C5 inhibitor after kidney transplant as prophylaxis, but given the evidence of new medications in C3G treatment, should we use iptacopan or pegcetacoplan to prevent C3G recurrence? We don't know the answer yet, but we're looking forward to more studies about it. For number 12, even though patient has a driver, patients had an extremely slow progress before kidney transplant, which may indicate low recurrence risk. I would not use prophylactic complement inhibitor in this case. Conclusions: C3G is an ultra-rare disease with overall recurrence rate around 60%. More aggressive native kidney cause is associated with recurrence. Background complementopathy is common in both immune complex MPGN and C3GN. May see changes in renal pathology over time. MGUS is not necessarily associated with C3G, but it may be an important implication for treatment pre and post kidney transplant. Complement functional and genetic testing can be used to identify drivers, monitor alternative pathway activity, and guide personalized treatment. I want to thank Dr. Jefferson for always being there for me, answering my question, guiding me through my project, and supporting me throughout my training. Your mentorship has meant so much to me, and a huge thanks to Dr. Smith. He's not here for helping me identify this, all these cases, and also going over the slides with me. Without them, I wouldn't have been able to start my project. I'm also deeply grateful to Dr. Blauser, who has always responded to me right away, no matter whether it's in night or on his vacation, and also, always answer my question as well, and provides unwavering support. Thank you. Special thanks to Dr. Ng and Dr. Flea for always paying attention to what I want and creating opportunities for me. I had a very personalized experience at VA, by the way. At last, but certainly not the least, I would like to thank all the faculty members who have been supporting me through my training and celebrating my small wins and being kind to me. I only have a few photos from the ASM, but the memories will go over beyond.